this webinar with me. Thanos, please.
Welcome, everybody. Today, it's a bit of a treat for everybody. Even though it's a webinar, all the speakers are gathered in the same room. And we're actually in Cambridge, UK, because we have the first EPA, that's the European Hip Preservation Society, inaugural focus meeting. We're hoping to bridge a gap, or actually build a bridge between the two societies, because the one is a continuation of the other. We have a fantastic faculty for you. We're going to have some talks, but we also have some case presentations. So without further ado, I guess we can start. Sorry.
So yes, we are going to introduce a little bit the webinar and what we are going to see in the next 60 minutes. So first of all, as you have seen, my co-moderator, Thanos Papavasiliou from Greece, and myself are going to coordinate this webinar. The first part will be based, we have a little change here. We will start with a case presentation. After that, we will have another presentation from Vikas Khanduja from UK, Innovation in Hip Preserving. We will continue with Moritz Tannast with the new concept in hip preserving surgery, how torsional abnormalities affect the hip joint. The next talk will come from Marc Tey from Spain about hip preserving surgery is doing well. A look at 10 years follow-up. And we will close the meeting with our friend from Italy, Filippo Randelli, who will do a nice presentation of a fantastic case from his hospital. So I think I will stop sharing this PDF. And as Thanos mentioned, we are now in Cambridge, starting this relation between the European Hip Society and ESCA-EPA section, because we have the same goals, and for sure this first collaboration will follow for another one next year or during the Congress in Thessaloniki. So let's move to the first presentation from Thanos Papavasiliou. We are going to start, as I mentioned, with this case of a very fantastic patient that he wants to show us. And let's see here with the sharing the screen. Now, I think we are ready to share the screen.
Good.
Thanos, you have the option to surprise us and have a discussion of your case.
Okay, fantastic then. I'm a little bit further close. This is a bit of a borderline case. It's a case that we actually closed the discussion downstairs just a few minutes ago. My disclosures, again, I wouldn't be the EPA chair if I wouldn't take any opportunity given to me to try to recruit you. If you're interested in hip preservation, do look into us. We're a close group of friends. We exchange ideas in something that is developing and developing very fast. So if you do a hip or a young adult hip service, it's not always clear cut. It's not always osteoarthritic. It's not always dysplastic. It's not always a level of tear. I wish it was, because medicine is at its best when it's black and white. It's most difficult when it's within the 50 shades of gray area. And this is such a case I would like to share with you. Now, this is a 44-year-old IT consultant. He's well built, a bit on the heavy side. He's actually working as a hacker for a bank in Greece, not to hack the bank, but rather to build up his IT defenses. So it gives you a bit of a sense of his mentality. It has hip pain over the last 6 months, which is affecting his activities and daily life. Because his job is sitting behind a computer for most of the day, he's an extreme sport enthusiast. He was airlifted twice from the Alps after skiing accidents. He had a tibial nail on the left side, or for the right forearm, and multiple other injuries. So that gives you a bit of a sense of what type of a person we're talking about. Clinically, he walks a normal gait. His flexion is restricted. His internal rotation at 9 is about 10 degrees, external 30. He has a positive impingement test and Faber test, leg lock negative, and he also has some psoas weakness and irritation that is kind of like radiating to his lower back. That's his X-ray. Now, everybody will agree that the right hip has already some mild osteoarthritic changes. This is not really a calm deformity. It looks more like an osteophyte, but the joint seems to be reasonably well preserved. And that's his MRI scan. It does nothing more than to verify that he has a level tear, that he has a bone cyst at the weight-bearing area of the sternum, and basically has early to mild arthritis. So that poses a question: what do you do with a guy like that? Okay, do you do everything by the book? Is it that easy? Do you do further imaging? I mean, there's a lot of talk in our section that you cannot go with X-rays or by an MRI by itself. Usually you do a CT scan, you check about his torsional profile and things like that. But doesn't this case, do we need any more? What's the plan? Do nothing? Ask him to change his way of life, inject the hip, scope the hip, or suggest directly a THR or even a hip resurfacing, since hip resurfacing is coming back. And that's a big discussion that I leave you to ponder about and maybe discuss at the end of the case. Well, in my case, I did, well, probably the not so obvious choice, scope him. Now, you see that he had a chondral flap, which is obvious. He was ready to come out. Now, you debride that as you do in these cases. And I'm going to take that slowly since I'm not sure if I'm talking to hip arthroscopists. So you have to go down to the margins to clear that down to the stable area. And then you do, as you would do in other joints, you do microfractures. If you take the fluid out, that's a picture that you want to see, that you want to see some blood coming out. And then obviously you have to repair the labrum and with a couple of anchors, and then also deal with the, I wouldn't call it, as I said, that a calm deformity is an osteophyte. In a case like that, that is borderline, I don't hesitate at the end to use some biological agents, in this case, a PRP. Now, as I said, this is a borderline case, and luckily enough, he did well. Now, this is in Greek, but I'm going to translate largely for you. You see him skateboarding, it's a year down the line, and says, well, doc, I did exactly what you told me. So thank you, etc. Is that always the case? No. Many times this goes south. That's why one of the most important papers that I read lately that changed the way I'm thinking about things is that this paper from almost 5,000 total hip replacements from the UK. Now, hip replacement is one of the most reproducible operations that we have. And basically, the question that they asked was this simple question: what is a satisfactory operation? And that entails three things. Is pain relief, is the hospital experience, but also meeting proper expectations. So when you're dealing with cases like that that are not straightforward, it's so important for you to be exactly at the same level, to discuss your patient, what to expect, and also the possibility of failure. Because even though this is a preservation section, well, this is a gray area. So also join us in Prague. This is kind of like a very small kind of like taste of what you're going to see. And I'm going to pass it to the next. Sorry.
We are going to discuss the case because we have time. So
Okay,
I think it's a very fantastic case. So remember all the attendees that you have the option to send your questions or your comments. But we have a very nice group of experts here who can say their opinion about the case.
No.
So, Professor Vikas Khanduja, can you tell us, come here, please, and do you usually manage this kind of patient because it's a limit situation? So, can you tell us something about the case? I mean, do you think it's a good option?
So, as time has gone by, I think especially it also depends on the system that you're working in. If you are going to land up to considering arthroscopic intervention in this patient, and if it fails and you're converting to a total hip replacement within 2 years, then technically the NHS as such is spending a fair amount of money, and economically, from a health economic perspective, it doesn't make sense. It may give the patient some pain relief, but for a healthcare system, actually it doesn't work. So it also depends on where you're working, what the patient expectations are. But certainly in my books now, this patient is beyond hip preservation surgery, and I would not be offering that to this patient.
Basic comment. We have also Moritz Tannast here. Moritz, what is your comment about the case?
Yeah, hello everybody, also from my side. So I think you were very brave to operate on this patient. Personally, I would not have done so, because I think if you have secondary changes like the osteophytes and all the bone edema and the cysts, then it's prone to fail. I would have probably just injected local anesthesia and some cortisone, and then done at a proper stage an anterior approach total arthroplasty. If you go directly for a total arthroplasty, then they might have wrong expectations. You need to talk about longevity also, and longevity aspect, since he's very young for total hip. But I would not have done anything regarding joint preservation anymore.
Okay, thank you. It's a fantastic comment. The case Thanos is amazing. I mean, in this situation, the patients are usually very happy and are really a good patient for the doctors who really manage this very young patient and very active.
What I wanted to make clear is that this, and it's clear from the registries and from our part as a section, that this is not an indication for preservation. This is an indication for pain relief, sometimes if the patient choice is correct. So it doesn't work all the time, and actually when they sign a consent, they sign a consent of the possibility of failure. It's pretty much the same as most of you have experienced with a knee. You have an arthritic knee. It is going to fail. Maybe for a short period of time, get relief, but 1 or 2 years for surgery and a long rehabilitation period, which is much longer than total hip replacement, might actually not be suited for everybody. So medicine has to be individualized, and that's a message I have to pass along. And the debate that we have among us.
Do you think there, I mean, we know from the knee in a kind of a prospective randomized manner that it does not work actually, and we do not recommend it anymore. Do you think we should go in the same direction also from the hip and maybe expose some of those patients either to surgery or not to surgery in a randomized fashion to answer this really in a good way? I mean, managing expectations and pain, I think that's very wise. So we did obviously a very good job of informing him. And he was intelligent enough to understand what's going on in his hip joint. But do you think that would be a good opportunity to go in this direction also with early osteoarthritis RCTs?
That actually might be a very good consensus I might suggest for ESCA to do. They've done it in the knee. It's another weight-bearing joint. So there might be a good idea to go down that road. Because what do you think?
Yeah, so my PhD student, Octavian Andronic, actually from Switzerland, has worked exactly on this FAI in patients with FAI and Tannast 2 and above, those patient cohort. And we've looked at 2 systematic reviews and also done a Delphi consensus on this. And essentially, there's clinical equipoise on this issue. You have half of the surgeons from around the world who would actually offer them surgical intervention in terms of hip preservation, and half will go conservative. So we are at a good stage for conducting a randomized control trial for this patient cohort. Definitely not Tannast 3, but FAI with Tannast 2 is the gray zone, which definitely needs an RCT to answer that question for sure.
Okay, thank you, guys. So I think we will move to the next presentation. Let's start with the presentation of Professor Vikas Khanduja that will talk about innovations. So it's a very nice topic that really everybody wants to listen. So let's see if Vikas, your time.
So thank you very much. It's very rare to have all the 6 presenting speakers in one room. So delighted to be amongst friends and doing this webinar. So innovation and how will our practice change? And how will this question that we were actually discussing change over the next few years. Bring you greetings from Cambridge. We are celebrating the 35th year of the first hip arthroscopy being done in Cambridge. So it is a big year for us. These are my disclosures, none of them particularly relevant to the talk. So this is how I think of technology in terms of training. How is technology going to help training? How is technology going to help in preoperative planning, intraoperative execution, and then how is technology going to help us in assessing postoperative outcomes? So if you look at training, obviously complexity of surgical procedures has gone up. Our training period, especially in Europe, and has gone down in terms of the hours spent. And rather than the apprenticeship-based model, we're now thinking of the competency-based model of training. So this change in training in terms of complexity of surgical procedures increasing, patient expectations increasing lawsuits, and more consultant-delivered care with number of hours decreasing and competency-based training. We need to think of something in terms of technology which would actually help us in training. So I'm being told by my moderator to stop.
There are some technical issues.
Oh, we're not sharing the screen. Okay.
Yeah.
So we'll have to start again.
I'm sorry.
That's absolutely fine, Oliver.
That's my fault.
This is technology talk. So we're doing well with technology here, for sure.
That's the problem. When we are assessing these technology things.
And the best part is that Oliver made me give my presentation to him on his computer so that we get it right.
Yeah, that's correct. I mean, the problem is when I want to share your presentation,
it doesn't allow you to share.
Yeah.
Okay.
Now.
That's
I think
we're
that's
getting
okay.
there. We're getting there.
Yeah. I'm sorry, guys. It's my problem.
Okay. Here we are. Filippo, can we see this?
Yes, sir.
Confirmed. Excellent.
Yes.
Okay, we are good. We start again. Innovation in hip preservation surgery. How's it going to change practice? So I'm going to skip through these, bring you greetings from our biomedical campus in Cambridge. Some disclosures, none of them relevant to this talk. So this is how I think of tech established over a 7-week period. So if you put all the evidence together for simulators in hip arthroscopy, essentially a great adjunct, but haptic feedback is an issue. It's probably more useful for earlier stages in training, but you need to be more critical with our evaluation of this technology because it's very expensive and utility needs to be established. That's concurrent validity. Whether it makes you a better surgeon in doing that procedure needs to be established. And collaboration with the companies who are actually developing this is the key to go forward. So that's as far as training is concerned. Now let's look at preoperative planning. We obviously done some work on this, which I'll share and where we're going in this. So the first thing to do in terms of femoroacetabular impingement is to understand the morphology, what exactly is normal and what is not. So we did some statistical shape modeling to define the normal head neck junction. From there, we obviously know how much to resect based on that statistical shape modeling. The second aspect is you may have a large cam impingement lesion, but you may not be using that impingement lesion and that's not be impinging. So it really depends on the dynamics of impingement and morphology. And that's where things like this from your CT scan come in, where you can do collision analysis and it tells you exactly where the impingement is happening. Obviously, there are issues with this model because it's only bony, it's simulated movement, it does not take soft tissues into account, and the femoral center of rotation also is suspect. But it does tell you, in a way, what exactly is happening. Smart imaging, we're looking at dynamic MRI scans itself. Shorter patients can get in. You can potentially get to do that impingement test on the table, but not for all the patients. And then 3D printing of complex deformities to actually make your operation smarter and easier. And then finally, looking at joint space. Again, we've done that through 3D CT scans. There are similar models available from MRI scans as well to look at joint space volume and depth. But essentially, this is where we are going. You want to have automatic segmentation and AI coming in. So your angles are calculated exactly accurately, where the cartilage delamination is. And the case that Thanos presented, if we actually put them through this model, you'll clearly know that that patient potentially does not need an operation, because you can correlate that with outcomes and this kind of imaging that you have. So preoperative planning and technology will go a long way as we go along, and these become available not only in research but in clinical practice. The second bit is intraoperative execution. How can we be more accurate in terms of surgical precision and accuracy? So we obviously know of this. We use that in our cars all the time. I started this work almost about 12 years ago, where we looked at navigated hip arthroscopy and how we can actually be precise. We then took that cadaveric trial into a first-in-human randomized control trial for navigation versus conventional hip arthroscopy. And essentially, we saw that if you were navigating patients, then you had basically accurate resection of the cam region, mainly in the 12 o'clock position. That's where the under resection was happening with conventional hip arthroscopy. But there is a lot of clutter in the operating room with the navigated hip arthroscopy. So we need to look at smarter things which can make life easier. So this is something which has come up on fluoroscopy. Stryker offers this. This is the hip map, and it gives you an intraoperative execution precision target of your cam lesion, the hip check output. But we've taken it a step further to make it easier with our university here with the robotics team. And this is what we've got. We've got the Franca Amica robot, and we've created that. And that you can see is actually resecting the cam lesion to a fair bit of accuracy and fair bit of depth as well via the robot. The other thing you need to establish is, are these operations worthwhile? So this is a good surrogate marker rather than waiting for 20 years to see whether you convert them into an arthroplasty or not. So this is discrete element analysis. All the patients who had accurate excisions of cam lesions, we put them through the DEA, and you can see that if you do a perfect cam resection, then you decrease or normalize the contact stresses in these patients with FAI. So fairly good surrogate marker to show why you need accurate resections. And essentially, it's not going to be only morphology, because what you're trying to do is change the contact pressure-based assessments. Finally, post-operative, you can do monitoring with smarter techniques. This is one of our physios looking at this, and we're looking at the prehab trial, where we're looking at apps like this called PhysiTrack, which will monitor the compliance and also how much you're doing in terms of exercise to monitor what exactly is happening. And then AI-based algorithms to look at large registry data to see which patients are going to benefit or not. And that's what we've already done with some machine learning tools on our registry. Finally, it's a complex interplay between morphology, activity and dynamics, and genetics. And therefore, looking at genetics also is key. So one of my PhD students, Ignatius, is looking at single cell analysis for patients with FAI, and that will come as well, predicting which patients with hip impingement are likely to go to arthritis quickly. So certainly, the more I learn, the less I realize I know, and there's a lot to go. And we've got a whole technology research program based on this. Lots of opportunities in hip preservation, both in research and surgery, and a lot more is going to get well-defined over the next 5 years. Final tip, you can't do all these things alone. You need to work with smart guys to get smart outcomes. So collaborate, and that's certainly the new competition, to do the smart things in 1.82 seconds. Thank you very much for your attention.
Thank you, Vikas. It was not 1.8 seconds.
That's fine. I know.
But anyway, I mean, I appreciate your fantastic talk. And we will continue our webinar with another great speaker that comes from Switzerland. And he's going to talk about another very hot topic. I mean, this topic is actually the presence of this torsion, this version and torsion in the hip joint, that we want to know what is the real meaning of that, and what are the our manage surgically with these problems. So I will introduce you again, Moritz from Bern, that is going to talk about these version abnormalities in the proximal femur and how to manage this complex situation. So, Moritz?
Yes, thank you. Can we see it on the screen and online?
Yes.
Well, thank you very much. Those were actually the fastest and the slowest 1.82 seconds that I've ever seen in my life in the slow motion. So, yes, so the concept about torsion deformities is actually not new. If you go to the literature, already Dietrich Tannast, he did a very nice job comparing the association between the torsion deformities and osteoarthritis. His big drawback was that he did not have an insight into the hip joint, so he was not able to check out what actually is the pathomechanism. And we do have now the opportunity to look inside and to fully visualize what actually happens with the hip joint, understanding pathomechanisms without harming the patient, harming the muscle or the joint with a surgical dislocation. So, and if you combine those two, then you will be able to understand what's going on with those torsional problems. Why is it so important? Just some numbers. Half of our patients that we see in our outpatient clinic that are symptomatic have abnormal femoral torsion. About 1/4 present with a severe femoral maltorsion. There are another 42% that present also with maltorsion of the tibia, and about 4 out of 5% with a pathological finding of version torsion. So that's something that is really problematic. If you look at this image, you can see on the x-axis femoral torsion with a range of about 80 degrees, and on the y-axis acetabular version, where you only see a distribution of about 40 degrees. So the span, the range of femoral torsion is at least twice as high compared to acetabular version. And then you need to measure it correctly. Just in brackets here, we do measure it with a 3 cut. So you need either a CT scan or an MRI that involves the hip joint center, which is level A, some point at the level of the base of the neck, which is slide B, and then also, of course, slide through the femoral condyles. And depending on where you put your plan B, you can have different measurements. Usually we talk about 10 to 25 degrees of a normal torsion. So if you measure different torsion methods or you have different reference points, please refer exactly to which method you are measuring, because you can have significant differences between the measurement methods. For instance, if you measure it according to Murphy, you will see that usually you have higher values compared to the Lee methods. So this means if you have a femoral retrotorsion with the Murphy method, it has to be a really, really low torsion. And you can end up with some sort of distribution of acetabular version in the y-axis and femoral torsion in the x-axis with all sorts of combinations. About 1/3 of the patients that we see have a normal version and normal torsion, and about 70% have some sort of problem. So the more you go to the right side, the more impingement you have. The more you go to the lower side, the more impingement you have also. And you just have the vice versa effect of instability. On the top right, you have the highest McKibbing index, which is the sum of those, with 7% having increased torsion and increased version. And you have the very severe impingement on the lower right, with 3% of all cases where we have a retroversion and a retrotorsion. And I'm talking about an unhappy triad if you have, in addition in those cases, a cam lesion. Clinical assessment is pretty standard. Just look at how the patient is sitting. So if they cannot sit straight and have to go basically into external rotation, it's a very clear sign for a retrotorsion of the femur. Low internal rotation, prone position compared to a high internal rotation, and some kneeing in with the gait pattern. In towing, out towing is not super reliable. The only thing that is really reliable is high in towing is associated with a high femoral version. If you have a neutral foot progression angle or even out towing, you need to measure it because it can mimic everything. Let's just have a look at the deformities. If you have, for instance, have a look at a high femoral torsion, what actually happens in those cases is you have a posterior impingement between part of the proximal femur. Here in this case, the lesser trochanter. It can also be the greater trochanter, and then you have a lesion of the anterior portion of the labrum, and also some sort of problems of the head, and also some sort of problems of the ligamentum teres. This is a case where you can see and also hear how the hip is subluxing. So we're looking on the right hip and doing extension, external rotation. And you can see how the hip is subluxing ventrally. Now, if you look closer with the arthroscope, you can see the right side how the labrum is sucked inside the hip joint with more subluxation. And this creates the typical lesion of the labrum anterior-inferior in those cases. As you can see here on the right side, it's usually a very fluffy labrum, somewhat increased in terms of size. And you can see here this empty labrum, which is not a typical impingement labrum. That is totally empty. You usually have two layers, very anterior-inferior. As you can see here, so the location anterior-inferior, which is a contrical layer, and here another case with the same pattern. Now, what we do in those cases, so here's a case where we have an extremely high McKibben index, so combined dysplastic hip and femoral antitorsion hip, and here we will combine both. So we will correct the femoral torsion, but also the acetabular version with a PAO and coverage with a PAO, and this through a surgical hip dislocation. If the patient is too old to do osteotomies, or if there is no subluxation but just a pathological contact, what you can do is just trim the posterior aspect of the greater trochanter. You can get rid of a pathological, painful contact posteriorly. That is something that I do whenever you don't have a clear subluxation in the dynamic assessment of the hip. If you have huge maltorsions, like 50, 60, 70 degrees, then we don't do a torsional correction only. You need to address this with an additional varisation to get a lateralization of the femur in those more than 20 or 30 degrees of derotation. The patients will have troubles of understanding it, especially their knee function and their gait pattern, and the abductor function as well. This is a case of decreased version or decreased femoral torsion, where you have an anterior contact, like a classic impingement, but without signs of an overcoverage or a cam lesion, and you will have the subluxation just in the opposite direction. With the same features, you have quite often a problem of the round ligament, which is torn. Here's a similar hip, but this time in flexion, internal rotation, and you can hear subluxation. Here we also have a cam lesion, and you can see on the lumbar protractor that we are not only hitting intra-articularly, but also extra-articularly. You can also show this with dynamic imaging if you want. And the labral lesion is just the opposite. So it's like bumped away. It's small. It's a very, very tiny labrum that is hard to refix, or in some of the cases, you even have to reconstruct it. And you have an adjacent cartilage lesion, which is more anterior-superior compared to femoral version anterior-inferior. And then you need to check if the problem is intra or and extra-articularly. On the left-hand side, you can see a case where we will just address the intra-articular impingement by scope. On the right-hand side, we need to do more, because if you get rid just of the cam lesion, you will still have an impingement on the extra-articular side between the tuberculum tertius, the anterior portion of the greater trochanter, and the inferior spine, which in most of the cases is 100% normal. This is a case where we just did an offset creation. This is a case where we had to trim the anterior portion of the proximal femur in an extended fashion in order to get the clearance of an anterior impingement. This is what we call poor man's rotation. So we give more clearance without actually doing a rotation. And finally, we have the osteotomy, which in this case is a rotational osteotomy to increase femoral version. And this is extremely powerful to give the patient internal rotation back. Last but not least, I would like to show you that usually in femoral retrotorsion and in those osteotomies, the hip wants to go home. You can see with the dotted lines my reference values or my reference K-wires. And I will do in this hip the osteotomy. And just watch those two K-wires. So without doing anything, the hip wants to go back in a kind of a neutral position, which is probably the best in terms of muscle pulling and muscle action in those hips. And those hips, I call it that the hip would like to go home. This is just a summary of an algorithm that seems to be complicated. You can check it out afterwards if you want to. That just summarizes in a more systematic way what I was just showing you before. And of course, I want to invite everybody to our next hip symposium in Bern, which will take place in 2026, February 5th to 7th. Everybody's welcome. And with that being said, back to Oliver.
Thank you so much, Moritz. Fantastic presentation. It's amazing how you manage all these fantastic deformities of the proximal femur. So we will continue with another speakers. We have seen many techniques, innovations, and many other fantastic surgery, preserving surgery. And now we will move about something that is very important, that is the results. So we are going to see how our friend from Barcelona, Marc Tey. Hello, Marc.
Hello, good afternoon.
And then he's going to present the results about the 10 years registries and all this stuff that hopefully will work in this computer. Now, I think it works. Now. Okay, Marc, now your time to present these long-term results with this preserving surgery.
Thank you, Oliver. Good afternoon, everybody, and thank you very much for organizing that fantastic webinar. And I'm very honored to be here with this amazing program. I'm Marc Tey. I'm from Barcelona, and those are my disclosures. I work in a public hospital in Barcelona, in Sabadell, close to Barcelona. And also I have my private practice in the city center of Barcelona, where we are dedicated to the hip. We do hip replacement and hip preserving surgery in both places. And in our outpatient clinic, as probably in yours, patients who are scheduled for a hip arthroscopy usually wants to know what's going to happen in the long term, and if that surgery will definitely prevent from hip replacement. And we don't have a clear answer to that question, but we must say something to them because it's the correct question, and it's normal that they want to know about that. Hip arthroscopy is an emerging technique, so it's difficult to do a clear answer to that. On the other side, you have surgeries like carpal tunnel release, where during the last 10 years, probably the technique has not evolved that much, and you can have clear answer to those questions. But with an emerging technique, it's not that easy. However, we have to look for the best evidence that we have, and we look for the works that talk us about long-term follow-up, and we can see what other colleagues are been publishing in long-term, and those are the results that they can present from the United States, from Ireland, and from all parts of the world with long-term results. That probably is the best answer that we can give to our patients. However, those are the individual series of different surgeons, and probably the best answer could be the average of those works, because then it talks about the results that we have, but also about the consensus that we have been having during those years where we have had meetings, where we have defined the better indication and the best techniques to treat our patients. That's why I think that looking to the registries will be definitely the best tool to understand what we have been doing in the last years. So hopefully in the next year, we will have long-term results with the registries in Denmark and UK. In Spain, we tried to organize also a registry. We did that Group Iberic of Preserving Surgery. We still don't have our registry, but at least we could join some surgeons with which we started at the same point, that we know each other, we close, know how we work, and we have some kind of consensus of indications and the technique. So probably it's a good approach to a registry. We did that work with 5 surgeons with a total of 500 hip scopes with more than 10 years for femorotabular impingement. And we had those results that probably it's the average of what we have in Spain. However, this told us about the results that we had 10 years ago with the techniques that we have 10 years ago and with indications that we have 10 years ago. And the surgical indication is in evolution. So in 2005, probably we have a huge amount of patients that during those years we have excluded from proper indication. First, we saw clearly that 10:2 probably was not a good idea, but then we saw that some patients, they have a combined dysplasia, and we excluded from the patients that with considerable indication. And then we started with the extraarticular femoroacetabular impingement or the abnormal torsions. So probably the indications today, they are much more selected from the indications in 2005. So in order to answer properly to our patients, what are going to be my results in the long term? Looking to the past, probably it's not the best idea. We do the same gestures, but the rest have changed. We have different tools. We have different knowledge and different environments. So probably the results must be absolutely different. During those years, indications has changed. Now we go to very low degree of the genetic joint disease with younger patients that in the past. We consider other diagnoses like combined dysplasia or abnormal torsions. We have different tools. We have different tools, for example, for management of the capsule. And we have developed new techniques like pivotless techniques and capsular management. So complications and results will be clearly different from the past. So in order to ask to our patients, it's important to see the registries. It's important to see what we have been doing in the past in order to understand where we have been. But our patients live in the present, and we have to give a different answer to them. Thank you.
Thank you, Marc. So now we can do a few minutes of discussion, and we can introduce the questions from the audience. So please send your questions about these fantastic talks. Remember that this is a combined webinar between European Hip Society and ESCA-EPA. So please go to the website of the European Hip Society and you can see this webinar in real life. So as we cannot see any questions actually from the audience, maybe I have some questions from here, from the panel of the experts. So I have one question for Moritz. It's fantastic. I think this new concept about torsion version is so important because change absolutely our thinking about the FII, for example, or dysplasia. So can you assess, tell us what are the x-rays or what you usually do in your protocol just to assess this torsion? Very simple, just for every orthopedic surgeon.
So, I I would start with the clinical assessment.
No, the clinical assessment
Imaging.
and radiology. Yeah.
So imaging, we still do a standard AP X-ray, which is important, and you cannot judge femoral version on AP X-ray. We measured that, and I think it will soon be published, that the indirect assessment of femoral torsion, with the shape of the lesser choke head, the shape of the proximal femur, is unreliable on AP X-ray, even if you want to do so. We do an axial X-ray also, and there you can, in some of the cases, see that there's very low space between the proximal femur and the ischium. But in all the cases, we do an MRI, and the MRI has to involve a distal cut of the femur. We also do in all those cases distal cut of the ankle, so we have the entire torsional deformity in addition, and you have to make sure that this is done within a very short period of time, so not that you have the proximal cuts at the beginning of your MRI section and the distal cuts have an hour afterwards. Or alternatively, if you don't have that available, you can also go for a CT scan.
Okay, and you have you say MRI. What kind of MRI do you usually order in your patients? What type of MRI? Standard one, arthro MRI, traction?
So we usually have our standard protocol involves an arthro MRI. It's a 3 Tesla Siemens scanner that we are using, and we do in all the cases traction. We use gadolinium contrast in those cases in order to get the degenerate index. And usually we do a stir image of the entire pelvis, so that we can also check for adductor pathologies or tumors, which are rare, but that you want to, or bone edemas, and then just standard axial cuts, radial cuts, and then sagittal and frontal cuts with traction. That's our standard protocol, which lasts about 35 to 40 minutes.
Amazing. Thank you so much. So any questions from the audience? Let's see in the chat. I think we cannot find anyone. No? So Marc, can I ask you something about your talk, Marc Tey? So it's also great to see that hip arthroscopy works, in the long term. So you want to assess this long term. What do you think is the main risk factor to fail your surgery in the long term? So when you analyze these registries and these individual studies, what is the factor that affect really to the results? The indication, the cartilage, what?
Everything has changed during the last years. So when you analyze the long-term results, you are looking to the patients that we did surgeries with the knowledge that we have in those days, with the technique that we have in those days, and with the tools that we have in those days. And everything has changed. So it's important to look at those registries. It gives us the clue to understand that we have to stop doing in even mild degenerative joint disease. We have to take into account different topics like torsional problems, or rigid lumbar spine problems, or even combined deformities. So we have addressed better the indication, and we have better tools. We know how to manage better, for example, the capsule repair. So looking at the past, it's something that we have to do, and it's good to look at the past, but it cannot give me the answer of today's patient about their results. Probably there is something that we still don't know, but based on what we have been doing, we cannot say what's going to happen in the next years.
Amazing. I think we are talking about the past, and the current situation of the hip preserving surgery. And thank you, Marc. Thank you, Tannast, and thank you, Vikas. And now we are going to close the webinar with a fantastic presentation from our great speaker from Italy, who always supports us, Filippo Randelli, that's are going to show us this surprise case, because we don't know what is happening in this case. Filippo, your time.
Close your microphone. Good evening, everybody. Are you seeing my screen? Ollie, do you see my screen? I'm sharing the screen now.
Yeah, you can see your screen, but you need to put in a presentation mode.
Yes,
No,
I'm
now-
doing. I'm
now
doing.
Now present.
I'm doing. Okay, so this is a case that it's not rare for us to see such young ladies, and the case is presented by me and done by me and by Dr. Manuel Giovanni Mazzoleni, who is my young partner that now left me to go to Bolzano anyway. So this is a female, 20 years old. She's a student. She's studying to become a nurse, a very nice and intelligent girl. The BMI was 22. I'm sorry, it's not written here. She had a past in the past. She was a former artistic swimming. She has a hypermobility, a Baton of 6, and a right hip pain. Okay. So the history of her right hip pain started in 2021. She also reported a kind of hip subluxation episode that was not confirmed by any image or exams. So she went on physiotherapy. She had a 3 hyaluronic acid injection and then steroids with no improvement. And at the moment when I saw her, the high hot was 32 and the non-arthritic score was 62. So she was in pain. She was not happy. And you have to do something on those patients. Even we don't like hypermobility patient, we have to do something on those. The physical examination revealed a further test of 3 plus. It means very painful. An anterior impingement, it means that you just flex the hip or pain. An abrasion test negative, a trochanteric pain positive, a normal tibial torsion, and no different on leg length. I'm showing now on the right, you have seen the done, and now this is the cross-leg X-rays, and move on. So when I say hypermobility, it's really an hypermobility. You see internal rotation of 60 on supine, on 70 in prone, and external rotation even more, 90 and 60. So is a problem for us, at least for me, a patient like this. So we ask for a Lido test. It's very important that the Lido test is written, and you see what happened. The trochanteric pain pre and post-op didn't change at all. The log roll changed just a little bit. What changed a lot was the anterior impingement sign and the fader. Okay, this really changed. Nothing happened to the Faber, or to the posterior impingement test, of course. This is again supine X-rays of the young lady. This is the pelvic tilt that was calculated because, as you can see, she has a wide distance from pubic to the sacroiliac joint, and also from the pubic to the sacrococcygeal joint. So this must mean something for you, of course. I'm giving you all the details, and then I will ask you what would you do, okay? Then the acetabular arc is 60 degrees, so almost normal. The CC age is 132. The Weber angle is 22, but pay attention where did I measure the Weber angle. So it was very strict, okay? So it was very strict. And the acetabular index was 13. The extrusion index was 33.4, and you see the normal value on the left over there. And then the fear index was 0.7, okay? Then we have a positive crossover sign with a positive ischial spine sign. Let's say a quite positive posterior wall sign, but consider the pelvic tilt, I mean, always when you are looking at these parameters. So the acetabular attenuation index was 35%. And this is the CT scan showing you different cut at different level. This was a higher level, and it was minus 5.5. But then if you go down, it going more towards antiversion. This is the pelvic tilt calculated on a supine patient, so maybe you don't need it. But you know the X-rays of the pelvis was done supine. This is a kind of, let's say, movable pelvis. I'm not sure it's very helpful, but it's nice to see. You see now a 3D reconstruction where you can have an idea, general idea of the shape of this proximal femur, especially. This is the alpha angle calculated on the down view on the left and on the cross leg on the right. And this is something that is most impressive for me. This is the ratio, the anterior head-neck ratio that is smaller than the posterior one. Okay, so even if you have an alpha angle that is not abnormal, of course, this is something that is normal, not normal. This is the femoral version as I'm using to do. So it's a very, let's say, not so, a little bit less than normal. This is the other way to calculate it that I'm not using now, but Manuel Mazzoleni loves it. So I will show you the Lee, the Reikeras, and so on. And this is the arthro MRI. I'm not going to describe it. I just want you to see it and to make your own idea. Okay? This is the not radial cut, but axial cut. This is the sagittal one. And now, what to do? So, for you, I'm giving you some idea. And also for, you can vote from home. I will going to read it. The first one is a PAO plus open femoral osteoplasty plus femoral osteotomy. Okay. That is not retroverting, it's anteverting, I'm sorry. The second one is PAO plus open femoral osteoplasty. The C is PAO alone. The D, hip arthroscopy, femoral osteoplasty, rim trimming, labral advancement, and then capsular tightening or replissage, as you want to call it. The E is hip arthroscopy, rim trimming, labral advancement, and capsular tightening. The F is hip arthroscopy, femoral osteoplasty, and just capsular tightening. So consider only the femur. Okay. Okay, so let's see if we have the result of the votation. Otherwise, I will start with you on the opposite side of this room to answer and tell me what you want. If you want to see other images, I can go.
Let's see. Can we see something?
Yes.
So, can you see me? Yeah. Okay. So, I have here again Moritz and Marc Tey. Marc, what do you do in this case?
I'm not sure they're hearing you. The microphone is on?
Yes.
Okay.
Okay. In that case, I think that I don't have enough information. In this kind of patients with hyperlaxity, what I found is that sometimes you have a torsional related to the inferior leg spine. It's more usual to have subspine syndrome. Sometimes not because it is really very big prominence, but because of the amount of motion that you have. So I would like to see, as you said, CT scan, it's nice, but I prefer to see it in a Lekesne view. On the other side, I think that it should be a torn labrum that justifies that very low non-arthritic hip score with that big result with the infiltration with the lidocaine test. So if it's like that, probably doing a labral reattachment. I think that doing a rim trimming here, it's a mistake, but maybe having a look to that inferior iliac spine can be a good idea. And I could see in some of the images of the magnetic resonance that there is a mild cam that probably in a regular patient, it's not a problem, but maybe with that hyperlaxity and with that increased movement, it can be the main cause of that lesion. So I will treat the femora. I will treat look at that labrum carefully, and I will look at the inferior iliac spine. And if I suspect that there is a subspine syndrome, I will treat it.
So
I mean, the iliac spine is here. You see here.
Yes.
You mean you will look at the iliac, I'm sorry. I mean, you will look at the iliac spine.
At the labrum at that point.
Okay, inside the joint. So you will see, you will not decide before, you will see inside the joint.
Well, I will try to look in the magnetic resonance, the labrum in that area. I would like to see the SNA in order to understand better the inferior spine. And if I have any doubt intraoperatively, I will look for some kind of fusion in the labrum related to that area.
So summarizing is you're going to do, let's say,
I would say E, but I don't understand lateral advancement. I will just do lateral reattachment if it's
no, I call lateral advancement when you do not detach the labrum. You just do a rim trimming, so you have the cartilage attached to the labrum, so you advance even and you reattach everything. So we call it like lateral advancement. It means you're not detaching the chondrolateral junction.
Okay. So Moritz, what's your opinion?
Yes, maybe go back to the apipelic X-ray.
Just a second, because I've put a lot of X-rays.
Yes, I think one thing for me that is different from left to right is I have the impression that the Shenton line is broken, or is starting to get broken on the right side. I also have the impression that there's some kind of upsloping source seal of the lateral corner here, in this case. And obviously the anterior conflict is her main problem. And she was responding well to intra-articular injections. So I would try to address the intra-articular stuff here. And for me, that would be a good case for a PL with a mild lateral improvement of the coverage, and also an anteverting correction, together with at the same time doing an osteochondroplasty of the femur. I would not address the femur for two reasons. One is, if you look at the values of Lee, they are usually lower than what we usually have. So I think if you measure according to Murphy, it's probably normal. And I think it would be kind of too much. I would just add one thing in addition. If you see during surgery that the capsule is quite lax, in some of those patients, what you can do is just do a duplicature of the capsule, like a tightening of the capsule anteriorly, which goes within the same surgery. I would do B.
Okay, fantastic. So, Filippo, what do you do?
So let's see. I did the scope. This is the ligamentum teres. I check anytime they talk about subluxation, a little bit loose, but not so bad. Then I uncovered what I thought it was a cam, and it was a cam. When at least my impression looking at it was a cam. I did just a mild rim trimming and a mild osteoplasty. I had a suture with 3-4 ankles. I don't remember. I mean, I did the labral advancement. I didn't detach the chondrolabral junction. Okay, so like this. Then I tested. I'm sorry, one video didn't work. Was the beginning, the assessment of the lesion. She had a wave sign, not a bad cartilage, but a wave sign on the anterior superior part. Okay, and then I closed the capsule. Actually, I did this scope, maybe not for the definitive treatment, but to understand what's going on in this hip, because it was very, very painful. So at the end, okay, this is the capsule repressage. This was the post-op. Yes, maybe it was too much in removing the anterior cam. This is the result. This is then we did is more than 1 year that we have done this surgery. And she improved a lot, and she still improved a lot. So I'm not sure, and you see she can move quite well, the hip. Quite well, I'm not saying completely. So the fact is, these are cases that are always tricky because they are very hypermobile. And so I suggest if you start with a scope and you look and you do something, doesn't mean that then you will not do a PAO or something more. But you just understand that the pain was there and you remove the pain. I suppose that maybe she could have a PAO. It's not a bad idea now. Okay. Thank you.
Okay, thank you, Filippo. I mean, can you stop sharing? So thank you, everyone. Thank you, everyone. So we can say from here, from Cambridge, that thank you to everybody who will listen our webinar. It was a fantastic opportunity to share with open surgeons and arthroscopy surgeons to see all the spectrum of the treatment and the news and the update in 2025 about hip preserving surgery. And it's a great opportunity of collaboration between two societies like European Hip Society and EPA-ESCA. So thank you, everyone. Thank you for staying there, and see you soon in the next webinar, 29th of May, about primary total hip replacement. Bye, everyone.
Ciao.
Recording stopped.